One of the paradoxes of the system is that we have now all recognised that integrated care is the holy grail, as it were. But when we set up the health service in '48, we actually deliberately created a disintegrated system in the sense that everybody had a general practitioner. And it was the general practitioner or primary care and the patient who eventually decided something was wrong. And the GP then functioned as a gatekeeper to then pass you through, as it were, to the other sector. The problem is that that does not create an integrated healthcare system. And it actually, if one thinks about the behaviours, GPs are set up against consultants, consultants are set up against GPs. So unfortunately, the system which we had is not integrated. So we've got to look at ways now in which we can begin to integrate the two. And that raises some very difficult and problematic political questions. But that, in some respects, is small beer compared to getting social and healthcare integrated. So how might we go about doing that?
You know, I think it's frankly very easy to do. I mean, I think it's very easy to say right now, at this very moment, we're going to integrate health and social care. The Chief Executive of the Health Service will also be responsible for social care, and we'll start integrating the system right now. We'll merge the budgets, we'll wrap the money around the individual and create care pathways that work for the patient rather than the current experience. And a frail older person might see 10, 15 different clinicians, carers, GPs, district nurses bouncing around the system in a most dysfunctional and painful way for that patient. So we need to connect the two systems right now, not in 5 or 10 years' time, connect them right now and begin to wrap care around those individuals. One other area, you know, we've talked about how the system is stuck in 1948. I mean, given the stage of biomedical science and practice in 1948, it made sense to have 200 odd DGHs, district general hospitals. Biomedical science has developed immensely since then, but we still find it very difficult because of the Save My Local Hospital group to consolidate. Can you talk a little bit about that?
Yes, the District General Hospital was a very good idea when it was thought of, conceived and implemented in the sort of 60s to 70s. And the idea was very simple: care close to the home. And when care close to the home is a fairly straightforward piece of surgery requiring anaesthetists, maybe 4 or 5 days in hospital, but with a pretty good and easy guaranteed recovery, you can have District General Hospitals. But as care gets more complicated and as procedures get more complicated, then the number of individual surgeons who, by the way, continue to call themselves general surgeons is vanishingly small. There's hardly any such thing anymore as a general physician or a general surgeon because, quite rightly, everybody has become specialised and thus better at what they deliver. So the DGH was a structure which delivered the healthcare for the 1970s. Now, one example of how this can be taken forward are the hyperacute stroke units, which is one of the great successes of the National Health Service, particularly here in London. The hyperacute stroke unit, there are 8 in London, and there was a huge discussion, not to mention heated discussion, about which hospital it should be, but most importantly, which hospital should not be part of the hyperacute stroke unit. And the discussions were obvious. How ridiculous to have somebody have a stroke, to race past in the ambulance 2 hospitals on the way to the hyperacute stroke unit. What the general public didn't realise, and you could argue why not, largely because they were not properly informed, was that none of those 3 hospitals could provide the type of care that you need in a hyperacute, which requires neurosurgery, sophisticated imaging, neurology, hematology, a whole range of specialties that you can only do in a small number of centres.
So you need to connect primary care and secondary care. And actually to applaud you for what you did, you reduced, despite the Save My Local Hospital, and I know there was a lot of resistance to closing, you reduced the number of hospitals dealing with stroke patients from 40 to 8, so with a lot of local noise, and reduce mortality rates, 30-day mortality rates by 17%. And coming back to health and social care integration, you know, we've got to look across the world for places that are doing this better than we are. We do have a couple of successes in the UK. Torbay is a famous one, but that was back in 2005, you know, and it hasn't scaled to the national level. Torbay drew on Geisinger Health, on Kaiser Permanente, to learn from them. Looking abroad, we can see that Israel has a fantastic primary care system, out of hospital care, integrated care really around the patient. So as a country, we've really got to sort of, understand what is happening in the rest of the world and try to bring that to the service of the UK citizen.
I think the United States is an interesting example because I don't think anybody is suggesting that the United States healthcare system overall is anything to be modelled. When we're talking about Kaiser or Geisinger or one of the other very successful healthcare systems, they are of course responsible for 10+ million people. So this isn't some sort of small little activity, it is something which is large. And the other exemplar which one would pick would be the Mayo Clinic, who run Mayo Clinics all over the United States. But every single patient who goes into a Mayo Clinic receives exactly the same care and has exactly the same outcomes as somebody who goes to the hospital in Rochester. We are agreed that overall the healthcare system in the United States is not good, but there are some very good exemplars which would translate very well into our system here in the United Kingdom.